Hello, my name is Mark O'Connor and I'm Head of Costing in the Healthcare Pricing Office. This is a brief presentation to introduce you to costing and to why we need to devote increasing resources to it. The HSE is implementing an integrated financial management system, better known as IFMS, within the Finance Reform Programme. Among the objectives are to collect data that can then be processed into information and insight that will enable the HSE to maximise the efficiency and the outputs of the finance and resource inputs that healthcare needs to operate. And I believe costing is best placed to provide that insight. So why do costing? Costing in hospitals allows us to compare unit cost both within and across hospitals so that we can measure how much our services cost to deliver. This is done routinely in private companies so that they can compare cost versus revenue. Costing our healthcare services will enable insight into where value for money is being achieved. This is a core objective of activity-based funding, where hospital budgets are being adjusted from historical models of funding and linked to the level and complexity of services that they provide. So if we look at two hospitals with a budget of 100 million and are only concerned with how much they spend, then Hospital 1 looks like it is performing poorly because it has overspent versus Hospital 2, which is below budget by €1 million. If we simply count patients, then this picture is reinforced because Hospital 1 has only treated half the number of patients of Hospital 2 and hence has a much higher cost per patient. But if we look at the type of patients being costed and allow for the complexity and expected resource usage, this picture becomes much more balanced, and we can see that in this example, which is obviously overly simplistic, Hospital 1 is actually the more efficient of the two. So this is a brief example of how the data in costing can turn data into information and then insight. Ultimately, what we are doing is to change focus of how we're funding our healthcare services, away from funding buildings or institutions and fund them in line with the services that they deliver to our clients. And this is a core objective of ABF. So if we look at a typical hospital general ledger, it is set up in cost centres, which generally relate to locations in the hospital where types of services are captured and reported on, such as wards, labs, theatres, overheads, generally where there's 4 walls in a building. And cost elements, which are the types of things consumed in providing the services, such as medical pay, nursing pay, drugs, lab supplies, computer equipment, etc. But patients are different and they consume resources in different ways. So a patient that has had a serious road traffic accident may come in through ED, move to theatre, then into ICU, and then onto a normal ward, all the time using diagnostic and paramedical services. Whereas a patient attending a fracture clinic will attend the clinic only and probably get an X-ray. A patient attending for a planned scope will probably just attend the endoscopy procedure unit with a sample sent to pathology only if needed. So our patients follow different pathways and use different resources. So the job of costing is to cut through the fog and attach and connect patients to the services that they use so that they can be allocated a cost. So how's costing done? Well, we match what has been spent and where with what activities have been carried out and link at either specialty or patient level. For the accountants, there can be considerable work in taking what is on a hospital general ledger and moving those costs as close as possible to patient service delivery through a process called reclassing. It is hoped that IFMS can incorporate many of these costing processes and make this process less manual. And the hope for activity is that there would be national systems that collect and output activity in a consistent manner, such as we have HYPE for admitted patients, NIMS for radiology, and Medlist for pathology. Every hospital contains a wealth of information that is collected on all of these systems. These systems tell us how many staff there are and where they work, and how much they cost, what type of services they provide, and what types of patients the hospital is treating. PLC is the only place to connect all of this data, and in effect it is a data warehouse. For admitted patients, we have HYPE, which tells us which types of patients are in our hospital. Have they had a heart transplant, or a hip replacement, or a stroke, all of which you'd expect to consume different volume and types of resources. Our general ledger tells us what types of expenditure have been incurred and where in the hospital that money has been spent. And our hospital systems tell us what type of services have these patients used. This slide is a simple summary about how we cost services, in this case for admitted patients. Overheads have to be allocated through statistics to each of our patient care areas. Patient care areas are then connected to the services that those areas have provided, which calculates a cost per service unit. Patient encounters that are linked to services in the service file are then allocated the cost for each service related to that encounter, which then aggregates up to a total cost for each encounter. So, if we look at our multiple trauma patient, they have used and been allocated a cost for most of the hospital services. However, the colonoscopy patient that had a routine scope only received costs for medical pay and the cost of the endoscopy room. The hip replacement patient is the only one to receive a prosthetic implant, so has costed the appropriate cost from that area. So the costing insight that this delivers us. Patients within a DRG should be consistent in terms of clinical profile and resource usage. So the question is, why do some patients within DRGs cost more than others, both within a hospital and compared to other hospitals? Why is it different? Is it more nursing pay or medical pay? Or is there longer length of stay? Are drug costs different? This will all become increasingly important when hospital budgets are more exposed to activity-based funding and when there is an increased focus on value for money and effectiveness, especially when the government seeks to recover the exchequer deficits built up during the COVID pandemic response. So this is why I believe costing can be at the centre not just of activity-based funding, but also activity-based management, which is being used successfully in other countries to manage and measure the efficiency and effectiveness of the outcomes of healthcare expenditure. I'd like to direct you to the HPO's costing website, where there's more information on costing process and documentation, and to which we are continually adding more education resources. Thank you for your time.